Okay, thank you very much, Lynn. So this is today my great pleasure to welcome Jeremy Veillard. Jeremy is the Vice President Research of CIHI, the Canadian Institute for Health Information, and Jeremy will tell you more about CIHI, what it is and what it does. Jeremy is also an assistant professor at the University of Toronto. Nobody's perfect.
Sorry.
And with the Institute of Health Policy Management and Evaluation, and is also the president of CASCO, the Canadian Association for Health Services and Policy Research. Well, I guess the best would be for you to start right now. Before you start, though, I would like to tell folks who will join remotely, and I think there are 5 of you, that Lynn is now allowing you to talk. And so if you have questions, if there is anything you would like to say, please interrupt. I know that Jeremy is happy to take questions while on his way. So please feel free to interrupt and ask questions if you have questions. So Lynn, sorry, how is it going to work? So are we going to be notified on the screen or anything?
They come over the speakers. We should be able to hear their voice over the speakers as long as they've done the audio setup wizard.
Okay.
And, yeah.
Okay, so anything you will say remotely will be heard in the room.
And will be held against you.
Exactly.
So good day, everybody. It's a great pleasure to be here. I've been back to Canada for about 2 years, and since I came back, I've been working with some people out of the center. We work with Julia Abelson on some qualitative research on how people or policymakers in this country understand health system efficiency, and based on that, we've been doing lots of quantitative work with Michel. So it's a great pleasure to be here. Your center is obviously very well regarded in this country as one of the great research centers. So I'm quite happy to have an opportunity to talk to you and talk to you about CIHI, and can talk about CIHI for hours. So you'll have to stop me at some point. But maybe what I want to do first is to give you a sense of what CIHI is. And I'm not sure how familiar you are with this organization. And maybe you guys can tell me. Maybe I get to start with the basics. Okay, so CIHI is going to celebrate 20 years next year. It was created in 1994. And it was created as the merging of a number of organizations. One of them being the organization holding the acute care data, started in Ontario and started expanding across the country. But basically in the early 90s, there was an ex-chief statistician of Statistics Canada, and he was tasked with making recommendations to government about the state of health information and what could be done to improve health information. At that point, it pointed to the fact that there were very limited standards and comparability was difficult. Quality of data was not optimal, and so there was a recommendation to create a new PanCanadian organization with a new governance model. And so CIHI is not an agency. CIHI is actually a non-governmental organization which is paid for by governments. And we live and die by the appetite of jurisdictions to share their data with us. So the way we function is that we have a board of governors, board of directors of 16 people, and it's really deputy ministers and system managers who are sitting on this board. We have a few ex-official people, so we got the chief statistician, deputy minister of Health Canada. But basically 82% of our funding is coming from the feds, the rest is mainly coming from the provinces. Residual might be coming from people purchasing our data or some products and services we are selling, but mainly we are selling to the provinces, and that's some advanced analytical tools that they might be paying for. Our budget, about $115 million a year, 700 staff. It's less than 2 years ago. We had about 800 staff, so we took a budget cut from the feds mainly, like any other agency. So we took about 5% budget reduction, and we had to decrease a little bit our FT complement, and we had to refocus slightly our operations. We discontinued some low-value products, but basically we keep on doing the same set of services. We're also an employer for some of you, possibly in the future. Since I came in 2010 as the Vice President for Research Analysis, I've been trying to strengthen links with the universities. So one of the things I did is actually to relaunch the hiring of senior researchers. We've had in the past senior researchers, and that's a level that is similar to managers. And it's been actually a very good alternative. There are actually relatively few positions, but it's been a good alternative for people who have done their postdoc and are interested in working a little bit differently with the data. Obviously, we can offer a few things. We get access to the data, we get money to do research analytical work, and you don't need to chase the money because the money is there for you. And we are actually also offering some flexibility for people to keep on working at the university. So we have a few senior researchers who are working 4 days a week with us, working 1 day at the university. Some people actually work less with us, more with the university. But we've been trying to give this flexibility. We also give the ability to people to keep on publishing. And they can publish either through the CIHI publications with one advantage, which is the fact that we have actually lots of media interest in our work. So every time we put a report out, there are lots of media mentions, and it really fits the policy debate. But people can also pursue, in parallel, analytical publications. Sorry, peer-reviewed publications. So we've been trying to be more flexible than we've been in the past. And maybe just to tell you a bit more about CIHI, like I was trying to stay away from the slides, but I understand that we have some people who are attending remotely, so I'll be showing a few slides. We have, and these are, we have about 28 data sets, and in terms of operations, we do different things. Obviously, we maintain a number of standards for comparability of the data, and that will start with, with the ICD-10-CA, which is a standard that's used for coding, across the healthcare system. But we maintain a number of other standards, working with a number of groups such as the Intera and so on. But basically, maintenance of standards is one of our key functions. We collect the data. We have 28 data sets. That's a lot of data. That's billions of data points. Some people say it's not even big data. I don't know what big data is. We can talk about that later. But we got lots of data, and we are actually hosting new data sets. So all the data we have will go from all the encounters with the healthcare system. So that will be all the acute care data, and we have different data sets for emergency rooms in Ontario and Alberta, which are the only 2 provinces we cover for this data set, to acute care data, for which we have actually every province in this country. Quebec has its own system, but we have found ways to map the Quebec data with the rest of the data for Canada, so we can actually have comparable information and indicators across the country, to obviously home care, nursing homes, rehabilitation services, mental health, and so on and so forth. So that's for sort of the acute part of our data sets. We also have financial data and costing data. We also have data about national health expenditures. We are hosting and maintaining this data set. We also have data about health human resources, physicians, nurses, other professions. And finally, we have clinical registries. The latest registry we have developed is around MS patients, multiple sclerosis patients. And that's one we developed at the request of the provincial ministries, but we have registries around joint replacements, organ replacement, and trauma, and so on and so forth. We have also developed over time a primary healthcare, which I would not call a data set. That's actually a prototype with the hosting of EMR data. And we were covering about 500,000 people across the country, but we came to the conclusion that this model actually was not very helpful, because a lot of this data actually is unstructured. It's free text. And the effort it takes us to send feedback reports back to clinicians showed us that it was not worth it, that the system was not ready, and the provinces actually are not ready to mandate structured data out of the EMRs in a way that we can use it at a pan-Canadian level. So we decided to step back a little bit. We're going to focus on standards for the next probably 2 to 3 years until we have enough of a critical mass of jurisdictions willing to implement our data standards into the EMRs through the vendors, and at that point we'll be able to develop a more meaningful data set for primary health care. So that's kind of the universe of all the data we're hosting. Sorry, Michel, you had a question.
So when you say that there are data for home care, nursing care, rehab, is that at the individual level? So that would be comparable to, I guess the data set that everybody knows here is the DAD.
The data, yeah.
Okay, so the discharge abstract database, that's for hospital and patient care. We have the information, or the information is stored at CIHI for all provinces at the individual level, so we can actually know what happened to a given patient when they entered the hospital, when they left the hospital. Is that the same for home care and nursing home?
Yeah.
Okay.
Yeah. So
all provinces?
No.
Okay.
So for nursing homes, long-term care, we have 8 provinces. Quebec is not part of it, and I think that Nova Scotia is not, but we are trying to cover as much of the country as we can. For the emergency rooms, we only have Alberta and Ontario, and we start working with BC. For mental health, we'll have very different level of information for Ontario and the rest of the country, much more detail in Ontario, less detail in the rest of the country. So we don't have full coverage of the country for everything, but there are a number of data sets, like most of our data sets, we have actually full coverage.
And for instance, is there any ability to link the same individual in the DAD and an individual in the nursing care, for instance, nursing home care
Yes.
data? So I can, let's say, if I guess I need to introduce a request, but CIHI could link those, what happened to a given patient across the healthcare system. That's something that CIHI could do for me.
Yeah.
Okay.
And we do that in our analysis.
Is it for you as well?
Yes, we can do it for you.
Yeah, how about Aboriginal healthcare, which is covered in a different money pot in Canada? Is that in here as well?
Yes and no. It's a very difficult topic. So we have had actually some analytical products on Aboriginal health. There is no identifier for Aboriginal status in our data sets, except for the organ replacement, and especially for the kidney diseases, because knowing what is your Aboriginal status is actually very important for from a clinical standpoint because of genetic factors. There are ways through which we can do some analysis, and that's more the geographical analysis, and these are methods that have been developed by StatScan, which we've been using for some analytical work we've been doing, looking at the density and proportion of Aboriginal people in certain geographical levels, like at relatively small geographical level. So we've been trying to do some work around that. So we've been trying to exploit as much as we can some of the information we have, but it's relatively limited. Now there are some pilots to use the DAD to start collecting additional variables that will let you link some of these equity variables with healthcare processes and healthcare outcomes. And so the Toronto Central LIN has been undertaking a research project. They validated a set of 8 variables. They had to be your language, your employment status, your income level, your ethnicity status. And so they are going to work with us to include this information in a special field in the DAD, so that we can start doing this sort of linkage with the acute care data. So there is some hope, but there is actually very little we can do. Obviously, one of the big challenges is that there are most Aboriginal people are living off reserve, and it's very hard to track them when they're because they are disseminated, and there's no way we can track where they are and how what are their encounters with the healthcare system.
I've just moved here from British Columbia, and I was at various conversations with Population Data BC. And I know that one of the issues for them was individual privacy and navigating that and having some kind of an ethics process that would allow them access to data. What kind of hoops do you have to jump when you're talking about individual linked data, and I'm not sure I want you to have my individual linked data, and how is that protected?
So we have our own privacy assessment process. So we got lawyers working for us, way too many lawyers. So the first thing is that there are, obviously we are submitted to the privacy requirements of different provinces. So we are compliant with that. For Ontario, for example, we are one of the 4 prescribed entities. So every 2 or 3 years, we negotiate with the privacy commissioner an agreement, and so we have very strict processes and procedures to do this sort of work. That ensure that we respect the privacy of the data, but also the security of the data. Every time we want to do any linkage study, we will have to go through a privacy impact assessment, and there will be a committee. Lots of people will be questioning why we want to do this linkage and how we're going to make sure that we ensure privacy. So we are as thorough as the university will be in terms of reviewing the ethics of the research.
So there will be the equivalent of a research ethic board within CIHI, but I guess it means also that I could access those individual linked data through CIHI, but I would have to go to CIHI somehow physically. The data could not be. Could the data be here, for instance, in a research data center, or would I have to go to CIHI, or would I have to send my code to you, or to somebody in CIHI who would then process the code and send me the results? How would that work?
Whatever we will do, we will never provide you with the data in a way that there will be any risk of re-identification.
Oh, well, that's fine. Okay.
Yeah.
So, but I could. So, but I guess the next question would be: you could send me something that.
I'm not going to send you the data set. I'm going to send you aggregate data, or we are going to do the analysis for you.
Okay, so that's more the ISIS model. Then I send you the code, you process the code, you send me the results.
Yes, I guess that would be the model that works. And so since we are at it, and since I'm not going to follow my slides anyway, so in terms of data access, so there are different ways to access our data. I've got to say that CIHI in general has not been as friendly to researchers as it should be or should have been, but that's something that we're making some progress, so that's actually helpful. There are different ways to access our data. So you can have a data request to us, and there are different ways we accommodate that. If you're a student, we have actually a program for graduate students, and it's actually free, so you can actually come up with very complicated data requests, and sometimes that takes us weeks to deal with them, but we'll do that for free. For when it comes to researchers, there's a cost. The truth is that there's an exemption, so I think that the first 2 hours are free. So if it's really a simple data request, usually, and just a few hours of work, you're not going to be charged. If it's a more complex data request, you are going to be charged something, but some people will actually include that in their CIHR grant proposals. We have different timelines depending on the complexity of, and I think actually I should have a slide here about that somewhere. Maybe I won't. Who knows? Did I just type that? Oh. Yeah, maybe. Yeah, 2 weeks. So aggregate level data request, 2 weeks for a standard request, 4 weeks for a complex request. Record level that would be 4 weeks for a standard, and 8 weeks for a complex. And then obviously if it's very complex, it can be negotiated. We've made very good progress lately in being compliant and consistent in the way we respond to that. I think often what's happening is that we have researchers coming to us and they're not actually very clear about what is their research question. So it takes some time going back and forth to really narrow down what is the question being asked. But in general, the team is very good at working with researchers on that.
But for instance, let's say it's, Mustafa or Phil, they have that, they want to submit a very complex, some kind of a, let's say, economic rate model, and so they have all the code written in Stata or in R. Would that be fine? So could they just send you, I guess they would have to send a project, a research question, and then they would send the code in Stata or R. Would you then process the code and send the results back? And I guess they would need to have some access to a mock file, to a mock data set, to know what the variables are and how it looks like. So with no information, no actual information, but at least to know how it looks like.
Yeah, so, we are SaaS users.
SaaS?
SaaS, we are SaaS. I don't know.
So no other...
Well, I mean, we can talk, but, if you want to talk to the CIHI people, you get to use SaaS. Otherwise, they'd be looking down at you like, who are you? Anyway,
okay.
We like SaaS, but I think that we can, obviously, we can use different statistical tools. That's not an issue. I think that obviously the problem for you is really to understand the variables that are accessible in our data sets, and it's been a challenge for us. So what we've been doing, we've been working in developing, and I'm not talking about the data actually, like I'm not managing the data, so there are some other people who know that much better than I do. I can tell you about research and performance reporting, which is really my part later. We've been developing research analytical files that we've put in and we are piloting that with the data which we've put in the public domain in universities through the university libraries. Now we've been doing that in such a non-publicized way that nobody knows about it. And I think in the last year we had like maybe 93 requests. I bet that our research analytical file is in your library here at McMaster. I would be surprised if it were not there, but I'm sure that nobody knows about it. So we have actually a new VP in charge of the data and is really trying to push making the data more accessible to researchers. So we're trying to make progress there. I think one of the problems is what kind of cut of the data set we can give you. And Kai tends to be very risk-averse when it comes to this sort of thing. So basically what we did is that when we developed the first research analytical file, we did it in such a way that we worked under the assumption that if someone wanted to re-identify people through this file, they will have actually unlimited resources, unlimited amount of time, which is just ridiculous. Nobody has unlimited resources and unlimited amount of time, which means that basically we narrow it down to 20% of what the file really is. So we're trying to revisit these assumptions, try to be a bit less conservative and try to optimize the use of the research analytical file for researchers, so at least they have a good understanding of what's available there. And so that's a pilot with the DAD, and we will want to do that more and more in the future. I think we're also exploring with StatsCan how we can make our information more available. So we have a data sharing agreement with Statistics Canada. They started linking through pilot projects our data sets with their data sets, for example, DAD and Vital Stats. I think it's very interesting. But even DAD and census and some of the income files. So there are actually lots of possibilities there. The problem is that they're doing it, first they do it internally and then it takes forever until they post the linked data sets in the research data centers. But there are lots of things that are actually coming, like they're in the pipelines. So all that to say that in terms of access to data for researchers, we're not where we want to be. And I think it's, for a couple of reasons. I think that, one reason is that, there was some, first, we have key audiences. Like, we really do this work for provinces, provincial ministries, system managers. There are key audiences. Researchers tend to be a lower priority for us, or tended to be a lower priority for us. I think that now we start realizing that we also have limited capacity to do analytical work and research work ourselves. Like, we're a very good group, but there is much more that could be done with the data. And we have actually fantastic, intellectual power out there, which is the research community, and in Canada and outside of Canada. And that's exactly what is happening in the UK, in England, with the Care the Data initiative, which is really a data liberation initiative. Put all this data out there as much as you can, being respectful of privacy, and make it available to various audiences, researchers, system managers, and tomorrow the private industry, because they want to, attract the private industry and they want them to use their data sets. So it creates jobs. Which I was just moderating a session with the Commissioner of Health for the state of New York 2 weeks ago at Health Quality Ontario in Toronto. And what the guy was saying is that now they make all their data sets publicly available. So they have like, research analytical file, and they have like all these companies who are developing mobile apps. So they deliver cardiac indicators on a monthly basis for cardiologists. Private sector comes, takes the data, turns that into mobile applications that are friendly for clinicians, created 150 jobs in 2 years. That's pretty helpful to know these sort of things. And it's a good community, it's a good service to the community, and it forces competition and makes the information more helpful and more relevant to people who can use the information. So I think we're slowly going in this direction. So I know that lots of people have been frustrated with access to CIHI data, but we're humbly trying to make progress. Any more questions about data? Yes?
Metadata, I know that, again, from what I know of Vancouver, sometimes the name of a variable and what is in the variable are not the same thing, and there's a problem with administrative data because the people on the front line who complete the data fields have local cultures, and that's how the data is created. And it's a known problem with this kind of data. I don't know the extent to which you try to document it or.
So, we're working really hard on metadata. So, we have a data quality department which is doing things like reabstraction studies, validation studies, data mining, and so on and so forth. One of the initiatives actually has been to centralize all the metadata about the data sets on our website. So if you go to the CIHI website and you search metadata, you're going to land on one web page where you will see all the standardized information about the metadata for each data set we have. That's for the databases. We're also publishing the metadata for our indicators. So that's all the technical definitions, exclusions, algorithms, and so on. And so if you go to indicatorlibrary.cihi.ca, we just released on November 7th a library with a first wave of 60 performance indicators. We'll have a second wave coming in the next few months. So it's all coming together. So we're really trying to make it much easier for people to understand what's behind the data sets, what's behind the indicators, what are the technical definitions, so that they can actually reproduce our methods and also understand some of the limitations around the data.
Yes. One last quick question on the data. That's what my perspective. So you mentioned that the vital statistics are now part of the CIHI data set. Is there any way we could link?
So it's the other way around. So that data is now accessible in StatScan, so they can do this linkage. We are trying to acquire the vital statistics, and we're working with Saskatchewan, British Columbia, and Ontario to acquire their vital stats, and not the entirety of the vital stats, the cause of death, to do work on voluble mortality and these sort of things. Or mortality rates at 1 year, 3 years, 5 years after hospitalization, these sort of things. So, so when we'll get this data, we'll be able to do the linkage.
Right.
But you should be able actually to work on that through the research data centers as soon as StatScan will have posted the data set.
Okay.
But they have done the linkage.
They have.
They have done it.
Okay.
One of the complexities for us in acquiring directly the vital stats, that actually the coding for the cause of death is done at provincial level in some provinces, but it's done directly by StatScan for some other provinces. So it really complicates things. So we're looking into how we can do it. Like, we can get it for Ontario because the coding is done in Ontario and then sent to StatScan, but some other provinces don't do their coding themselves. So they could send us their data sets, but then if we have to do the coding when it's already done by StatScan, it doesn't make lots of sense. The other thing we're trying to do in terms of data is actually to acquire new data sets. And so, for example, we're working on physician billing data. We're developing a patient grouper, which is very important for activity-based funding, and lots of, at least 3 provinces are putting lots of efforts in activity-based funding. They've been using different types of groupers, but they're mainly coming from, the US, and they're really adjusted for the characteristics of American populations, not Canadian populations. So we are trying to develop a PanCanadian grouper. When we do that, we need the physician billing data. It's very important to us. So we start receiving some of the data on the physician, on fee-for-service. And that's actually very helpful to us, because then we can link and see what happens between the community and the hospitalization. So if I take just a couple of examples, or maybe just one example, we have a study that we'll do in the next 12 months, which is around trying to understand discharge practices out of hospitals. And so, people get discharged when, what's happening, people who are being readmitted to a hospital, have they actually seen their physician within 7 days or not? And we can do that by using the fee-for-service data. So that's one more example. Other initiatives are on new data sets that are really priority for us in terms of development. Mental health is a big priority. We have some of the mental health data, at least we have OMERS in Ontario, but we'd like to develop that across the country. We'd also like to develop data sets around community mental health. So we're thinking about it and developing some plans, and obviously that will be work we'll do together with the Mental Health Commission of Canada and other partners. We've been working with jurisdictions to develop a pan-Canadian patient experience measurement tool. So today there are actually various tools that are used across the country. It's not comparable, it's not standardized, and it's frustrating lots of people. So provinces came to us and asked us to work with them to develop a tool. We use the HCAPS, which is a US-based tool which was developed by the AHRQ, and based on that we've been developing Canadian content, and so we are just at the stage of finalizing the instrument and going around provinces to get some money to develop the data set. The other priority we have is around PROMs, patient-reported outcomes, and we are developing a strategy around that. And I think that, you see, I would say that we focus on PROMs and PRAMs with the experience measures, and we're also trying to augment all the costing and financial data we have, because there are lots of questions about value for money. And what value do we get from our investments, and what are the true outcomes, the true costs and the true outcomes of investments in healthcare and new interventions. And you can only get there if you have information about utilization, which we have, information about cost and financing, which we have in an incomplete way, but we need to have information about outcomes. We need to have data about experience and data about patient-reported outcomes. If we can also look at things like mortality over a longer time period by linking the vital stats with our utilization data, then we're in a very good place to have more meaningful measures of outcomes of care and cost of care. And so, therefore, getting to the issue of value. But I'm not responsible about data, so I'm spending way too much time talking about data. I want to talk about the rest of the stuff.
Okay. Okay.
Can we go into the rest of the stuff? Okay, and maybe I should ask on the line if there are people who want to ask questions. There was a microphone.
Yeah, it's there. Mm-hmm.
So any question online? No? All right. Okay, keep going. So when I came to CIHI, I talked to someone I hired later, and she was talking to someone at the university who said, "So CIHI, you're not really doing research, you're just doing analytical work." So that was actually very interesting to me, because I'm not really sure I understand the difference between research and analysis. But I think that we are actually doing lots of research at CIHI. We're doing actually lots of very interesting and very original research, but sometimes we have more policy people working in provincial ministries know about it than people working in universities. So what I want to do here is just to give you a bit of a sense of what we are doing and why we're doing it. And maybe the first thing to do is to explain why we're doing what we're doing. Our mandate is really to support better decision making so that we get better outcomes in the system. But that's what we do. And we work very closely, and we are probably one of the organizations in this country who have the closest relationship with people who make decisions. We work with provincial ministries of health, we work with people working in regional health authorities, we work with people working in hospitals, long-term care homes, and so on and so forth. But we are very closely connected through advisory groups, through ongoing engagement mechanisms with these people. We also have a board of directors which is representing provincial ministries and system managers, and these people are giving us lots of very good guidance about our research and analytical work. So what you see actually is work that is very much aligned with the priorities of provinces. We want them to tell us what they want us to do. And obviously what we do has to fit with our mandate. So in the past, CIHI has done lots of work which was really, and which was really a reflection of the data that was available at CIHI. I think more and more what we are trying to do is to tell them, tell us what you want to know, and then we're going to strike the right partnerships. We're going to work with others so that we can actually answer your research questions. And so, that's basically what I was saying. If you look at, and that's on our website, you will see we published a month ago a health system performance framework. So that's just the way we, I guess, see the world, but that's both theoretically grounded and aligned with strategic priorities of jurisdictions. But what you see is that there are really 4 blocks here. You have one block around inputs and characteristics of the system, so what are the resources, leadership and governance, efficient allocation of resources, adjustment to population needs, innovation and learning capacity. So it's all the inputs and system characteristics block of the system. These are the outputs, and that's really the services you deliver, both to populations and individuals. And this, we see you want these services to be accessible, comprehensive, and integrated. And then they have a number of other characteristics. These are the outcomes, improving the health status of Canadians, improving system responsiveness, value for money, and obviously with an equity dimension. It's very much aligned with other international frameworks. What we've done as well is try to show the logical path between health system stewardship, intersectoral action on social determinants of health, and impact on outcomes, because obviously the health status of Canadians is much more impacted by social determinants than by the health system intervention itself. Now, what's interesting is that when you start mapping actually all the type of research that we do at CIHI, you can see that we are covering lots of ground here. And what I want to do is actually to give you an example, or maybe a few examples of some of the work that we are doing. So when it comes to social determinants, we've been doing some work on Aboriginal health around cardiac care and heart attacks. We're also working on health inequalities. So we are actually now working with the Public Health Agency and Statistics Canada, and there are a couple of different projects. One of them is to take a few key indicators of health inequalities, look in depth over a long time trend, try to understand what are the policy, first try to understand what's happening, if things are getting worse or better, but also try to understand what type of policy interventions actually might have had some impact on health inequalities. So that's one type of project. On inputs, we are working on health system efficiency, and that's work that we've been doing under the great advice and guidance of Michel. But I think that what's very interesting is the sort of angle and policy relevance of this work. We started doing this work actually with our population health team. Some people were saying, so, like, what's wrong with you? So you're working with a health economist on efficiency with your population health group. And I told them, you will see why in the end. So 3 years later, I got the answer about why I did that. I did that maybe because they had money and still their money. There was a more serious reason, and it's, I would say it's very twofold. The first one is that when you look at the results of this study, what it shows us is that we can explain about, confidently about 50% of the variation. So, there's a 25% variation between the most efficient health regions and the least efficient health regions. Now, when you start explaining why this is, why you see these results, there are two sort of conclusions. The first one is that you can only explain about 50% of the variation through existing measures, such as clinical effectiveness measures, operational efficiency measures, and so on and so forth, and some of the population determinants that we can find. The other 50% is likely to be explained by variation in population health characteristics. But even if you take this 50%, what you see is that there are lots of provinces are putting in place policy interventions such as activity-based funding, and basically they do that to improve, the efficiency of the delivery of services. Now, what's interesting is that what we know is with our study is that if you only do this intervention, you'll only be able to fix 50% of the efficiency gap. That's the first thing. The second thing we can find is that if you don't have actually the right adjustment models so that you can adjust for the characteristics of your population, you're likely actually to punish the ones who have a worse starting point at the beginning, because lots of this variation is explained by the characteristics of your population. So in terms of design of your funding model, I think that our findings actually have quite large implications, and it's then creating actually a fascinating discussion at the policy level about the fact that if you want to improve health system efficiency, you might want to do some interventions around clinical effectiveness, operational efficiency, work on things like readmission rates, lengths of stay, ALC, and these other things. But you have to put probably as much effort in more upstream factors around determinants of health, health promotion, and disease prevention. And that's just to get to the outcome that we have in our model, which is actually which is potential years of life loss from treatable conditions. So anyway, some very interesting study which starts with more of a healthcare focus, but ends up with lots of on phases to population health interventions as part of the conclusions. So that's why I asked my population health team to do this work. Another study which is very interesting, because I never really used to do that, is that the redistributive impact of the health system. And again, a very different angle. We used a micro simulation model which was developed by StatScan, and basically we tried to simulate the effect, or we tried to understand what is the redistributive impact of the healthcare system by income quintile. So we're looking, how much are people spending, through their taxes, and how much are they using the system. So how much they contribute, how much they use. Very interesting findings. There is a redistributive effect which is around 16%, which is not very different from what we found in the literature. But what is very interesting is that when you look at the relative proportion of income taxes which is spent on healthcare by income quintile, it's not hugely different. It goes from 4% for the poorest people to 8% for the wealthiest people. Now, our system actually has a very profound protective effect for the poorest people. If your lowest income people didn't benefit from this redistributive effect, they will actually be spending 25% of their disposable income on healthcare, when today they're spending 4%. What does that mean? Is that people, we have a system actually that is protecting the poorest people in Canada. If we didn't have this system in place, what will happen is the same thing that will happen in the US, is that lots of the poorest people actually will be thrown into catastrophic expenditures and poverty, because the system is not here to protect them. So that's actually very interesting that CIHI, which is mainly working on retrospective data, actually has worked, doing work on micro simulation with tools that can develop, which they are not using as much as they could, but we've been going way beyond the usual scope of what CIHI tends to do in general, which is more like healthcare utilization type of study. Another example of a product we just delivered with Health Quality Ontario, but really where we did all the analytical work, is that we developed an algorithm around heavy users. And our algorithm actually uses our linked data sets for acute care. So we use the emergency room data and the inpatient care data. And we developed an algorithm with a sort of number of predictive factors to anticipate when people start becoming heavy users in the system. So usually you have like this sort of, curved, this bell curve where people are not very heavy users of the system and then they start using more, and that's what you want is to prevent them to go on on this curve. You want like to smooth it down, and what we're able to develop is actually a model with 7 variables, which are actually screening factors for people going into a primary health care team. So you go to a family health team in Ontario, people now can screen you, and now Health Quality Ontario, that's part of their model. They're developing very practical tools for physicians to use this algorithm, but they can screen, and if the person meets these 7 criteria, you know that this person is very likely to become a heavy user in the next 12 months. So you can actually start putting in place strategies to avoid that to happen. So that's just one example of some other analytical work that we are doing.
And sorry, are you not worried that teams can use that to select patients or to turn down patients? Say, well, this is a patient that I'm not sure how the resource allocation formula has been built, but if they're not more paid for that kind of patient, they might very well say, well, I don't want to deal with that patient, it's too risky.
It is economics. You guys are conscious. Don't you think that people are trying to do the right thing and take care of their patients? So more seriously, there is an initiative in Ontario, which is called Health Links, and I think that what they are trying to, I think obviously health quality, we did the research and all the analytical work. Now what they are doing is that they are thinking about the policy interventions they could take. So that would be one of the potential negative effects. I think they are trying to be thoughtful at it and try to see through the health links, or they could use that in a way that obviously is not going to end up with selection of clients, but is going to end up with early intervention so that we avoid them becoming heavy users.
And sorry, go ahead.
Well, I was just going to say that the very term heavy user is stigmatizing.
Yeah.
And that you might want to think about the impact of the language you use on the way in which people are treated.
Yeah. I'm being very informal here. I'm not even sure if we call them, I think we call them high cost user. I don't know exactly what is the language we use, but that's a fair point.
And was it published, or is it going to be published?
Okay. No, it's published on if you go to the HQ website, it's actually on their front page.
Oh, sorry, I meant in a kind of academic publication, because that's kind of an algorithm. If you can predict whether somebody is going to be a high-cost user, I mean, that's something that, as you said, that's research. But
yeah, so we have the so there is an executive summary with the conclusion, like the methods and the conclusions, but all the technical notes, everything has been documented, and we are sharing that with. It's actually Health Quality Ontario. They are the ones who are owning the product now, but you just have to ask them, and they will be sharing the algorithm with you. It's been developed in SAS. Sorry, you have to translate that into some other statistical software. Just some other ideas about some of the work we are doing. So, obviously work on wait times, aging, variation in cost per weighted case. So that's the average cost for a hospital stay. That's something we are looking into. Some other work we've been doing on avoidable mortality. So we developed a Canadian methodology for avoidable mortality and looked at it over a very long time period. It was very, very interesting findings here. It was our biggest hit last year. We had more than 300 media mentions with what people called avoidable deaths. But that was a really fascinating study. We're going to do more research work on that next year, and so on and so forth. So, we've got every year we have about 20 research reports, which are like these sort of 25 pages max reports. We call them analysis in brief. And then in addition to that, we keep on publishing, but a bit less. our annual reports, and probably the one you will know the best is the National Health Expenditures Report. So that's not really an analytical report. We've done, though, lots of analysis on that, and we had a study on healthcare cost drivers, which actually was one of probably our biggest hit the year before. In 2011, lots of interest from provinces on that one. But that's 2012-13, and that's 13-14, and that's 14-15. And now we're already working on 15-16, but we're looking at things like appropriateness of bariatric surgery in Canada. We're developing new indicators of wait times for cancer surgeries. We do some analytical work there. Some more work on high users. Don't call them heavy users. They're high users. Some very interesting work we are doing is we're developing a new indicator of harm to patients. And that's harm that's happening in hospitals and that's treated in hospitals. It's very complex work, very difficult to deal with for the clinical community because they are used to adverse events, they're used to errors. Harm is a little bit different. Some of the harm actually is not avoidable, but what we are working on and our operating definition is to try to map out any kind of harm that is actionable, for which there are actually best practices, and we work with the Canadian Patient Safety Institute to develop a library of best practices and CPGs to take action on that. It's quite high. It's between 7 and 10% of hospitalizations result in harm to patients. So the day we make that publicly available, you'll be hearing about CIHI. Interesting. And there's a huge cost, obviously, to the system. So now I'm going to talk a bit about some of the performance reporting work that we are doing. Do you have any question about our analytical work or research work? Did you know that CIHI was doing this sort of work at all? No idea.
And if we, let's say, if a researcher wants to be part of that, I don't know, some let's say you have that, your analytical plan, and I guess it's posted on your website.
Yes.
If somebody's, let's say, this is the area, I'm an expert in that area, I really want, or I'm developing an expertise in that area, is there any way I can contact CIHI and say, absolutely, I'd like to be part of that? Yeah, look at that.
Yeah, so you can go to our website, so you have our analytical plan for the next 2 years. Typically, we update the plan in, we go to our board of directors in March, they approve it, then in April or May at the latest, you will have the latest plan for the next 2 years. It's a rolling plan. And if you go to our website, there's actually an email you can write to. So if you don't know who to contact, I don't know if it's called analyticalplan@cihi.ca, but you can find that on our website. So just go to the search function, analytical plan, and you'll find all the information you need. For any study we do, we have an external advisory group. So we are working with academics and experts on all our work. Usually it's a relatively small group, that depends a bit on the project. But if you think that you have a specific competence or interest and want to collaborate with us, let us know, absolutely. We're very eager. Okay, performance reporting, that's my baby. That's my PhD, my baby. Okay, what I want to do is to show you our new website. Have you seen it? Do you know our health system.ca? Okay, so we've been asked by a number of federal and provincial governments to build a website for the public, for the general public. There's lots of information on performance out there. It's very confusing. There are too many indicators. There's too much overlap and contradiction between what lots of players are doing. Everybody's putting out a performance report. You get the CBC doing Rate My Hospital. You have the Conference Board of Canada rating the provinces. You have the Health Council of Canada putting out their own report. CIHI doing all their indicator work. The provincial quality councils doing their own work. Academics sometimes doing their own performance ranking. There's one in Saskatchewan who's doing it. So there's lots of information out there. It's very confusing. So we're asked, fix it. And try to come up with something that is meaningful and start with the general public. And come up with very few indicators. So what did we do? We asked the public. We asked people, what do you want to know about how the system is doing? And we had...
Oh, sorry.
What's going on? And we had an external firm carry out online surveys and focus groups across the country. So we reached out to over 3,000 people, and they went through a sort of online experience, 45 minutes long, in which we explain what is health system performance, what are the different concepts, what do they mean in practice, in real life, what do they translate, and we ask them actually to score these different dimensions of performance, if you want. Very interesting. They come up with 5 themes, very similar across the country. You look at every province, it's almost the same. You look at income levels, rural, urban, age category, slight differences. So, people who are older will tend to rate higher things like access to care. People who are a bit younger tend to rate higher things like health promotion and disease prevention. So it depends what stage of your life you're at. So that makes some sense. But lots of similarity across the country. They came up with 5 themes: access to care, which is obviously the dominating theme in what people were telling us; quality of care; health system outcomes; value for money; and health promotion and disease prevention. These were their priorities. Based on that, we work with national and international experts to select a small number of indicators. We say 10, we got 15, that's okay, we live with 15. And we developed a website which we try to make very visually appealing to the general public. Okay? So the difference between this website and any other website that we've done is that lots more infographics, dynamic and static infographics, lots more capacity to or capability to tailor the tool and to share the tool through social media. So I'm just going to give you a very quick demo of the tool. Basically, you have 2 different ways to enter the website. One of them is by theme. So if you click on access, you're going to see at very high level, what access means, what are the 4 indicators we have here, and you've got people who have a regular doctor, wait times to see a specialist, radiation treatment wait times, joint replacement wait times. And then what you can do is just to select any indicator you want. What do you guys want?
I was interested in the cost one on the prior
All right,
page,
let's get back.
because I was surprised that it would be a priority what it costs the system as opposed to
Oh
the
yeah,
individual.
people love stuff that costs.
Yeah, they
So,
quite like the system.
so it's a bit of a proxy, because we're talking about spending here when really people were asking about value for money, but there's no real good way, at least we don't have very good methods to measure value for money now. But as I told you earlier, we're really working on that. So you've got public spending per person or average cost of a hospital stay. This one? Taking this one because what you can do actually is to drill down to the hospital level. So you have much more information if you want to know more information, and you have a little video around this information. Then you've got some infographics, $60 billion spent a year on hospitals, then some of the categories of spending and some of the variation in some of the results. And then we get to the interactive part. So what you can do is that you can find here the average cost of a hospital stay, get a Canadian average, it's broken down by province, and then you have a color code about higher than average, same as average, and below average. So if you go, let's say, to Alberta here, what's going to happen is that it's going to populate directly these trend graphs. So you're going to see for the last 3 years what has been the trend in terms of average cost of hospital stay. We only have 3 years of data because we change our methods here, but for some other indicators we have actually a much longer time trend. What you can do here is that you can actually add some other provinces. You can only do 3 provinces because we really wanted to keep it simple. What you can do as well is that you can add a city, so you can add done. And so it's going to add 1 line here with this color. We don't really see very well the color. It's not really the city, it's actually really your LIN, so your local health integration network. So that's a proxy, and we can add a hospital. So this is Hamilton Science Center. It's our hospital. happening? What's going on? Sorry about that.
There it goes.
Oh, I think we have a bit of a problem. Anyway, Toronto is going to work. Telling you. Just for you. That's the first time I see this problem. Anyway, you can add a hospital. Who cares? Now, what you have also is that you have actually a mapping capacity, so you can look at the map and you can drill down into Ontario. And if you go into Ontario, you go into the GTA here, and you're going to see what is Hamilton?
Hamilton, down.
Down?
Yeah,
Here,
here it is.
Here's Hamilton. So you will have, you can see actually the variation between some of these. Here it is. It's a teaching hospital. Here we are. Now what we did in addition to that is that for some indicators such as hospital readmissions, we have actually also published the top results, top performers, and really we define that as top decile 3 years in a row. And your results, you get to make sure that your confidence intervals don't overlap with the peer average. Yeah.
Is there any ability to sort of dig down on the reasons why? So if the cost of a hospital stay is higher in one place than another, is it because the average hospital stay is longer there, or is it because they're somehow less efficient?
Yeah. So when I talked about our analytical work, I think I just went briefly over that, but we are actually doing we have a research project on explanations for variations in cost per weighted case. So obviously, if you look across provinces, a big explanation, for example, between Quebec and the rest of the country would be wages. But there are lots of other explanations. So I think it's interesting when you start actually triangulating some of the other indicators for a hospital. Now, you get to remember that this is a website for the general public. It's not really about hospitals, but we are building actually a new hospital website. We have one already with about 30 indicators, but in this new website you'll have actually much more performance information and contextual information, so you can start looking at things that do you guys actually have, like a longer length of stay, what percentage of your budget you'll be spending on nurses, other things. So you can have like some of the explanation there.
So then I guess my next sort of question is, on a broad picture, what's the I mean, obviously it's to provide information, but what's the purpose of providing the information? Is it with the goal of sort of saying, so now I say, oh, well, it's going to cost more to go to Hamilton Hospital and hope that I go to a cheaper hospital, or is there some sort of behavioral expectation? I mean, I learn this information and then do something different because of it, or is it just so I know and feel good about that we're...
No, I mean, I think at a broad level, what we're trying to do is that, and that's part of our mandate, we promote transparency and accountability. And what we're showing huge variation, including variation. So, seeing this variation is not going to change your behavior as a hospital patient. However, this is very helpful information for someone, I don't know, who's working in Alberta and wants to compare across the country and see a huge variation, in terms of, and we show that in one of the results, like the cost of a hospital stay goes from $4,000 to $9,000 in this country. And sometimes there are good reasons for that, and sometimes there are no good reasons for that. So that's really an instrument at the disposal of system managers and policymakers. In that case, we don't think that we're going to drive healthcare consumption behaviors at this level, but we want people to be more engaged in discussion about their system, and we want them to ask for decision makers to account for this variation. So there's huge variation across all these indicators. Now, that's what I would say about acute care. When it comes to long-term care, I would argue that people actually are very interested in the quality of long-term care services, because when they make a decision about putting a parent in a resident home, they want to know about cost, they want to know about quality of services, and they want to know about quality of life. And we have developed a set of 25 indicators of long-term care quality. It's not publicly available, but we're going to make them publicly available next November. And we are already thinking about things like a mobile application for people to understand the quality of care delivered in nursing homes. And I think that would drive some care consumption patterns.
So then would nursing homes enlist voluntarily you know, and being part of the statistics, like would there be a similar map where you check out the quality of care?
Yeah.
I mean,
So-
really, it's very controversial, I would imagine, given
Oh, yeah.
the limited amount of
So it's
overseeing there is in Ontario.
yeah. So first, it's happening already because you have. I told you I can speak for 4 hours. Can
Yeah,
I
but
just answer this
but
question?
yeah, sure. Yeah, but we have a constraint, which is that if we want to have lunch, we have to be there before.
Yeah, by before 1:45, but if you miss it, then I guess you just have to go somewhere else.
Okay.
Is there a pub next door?
Maybe, yeah.
So Health Quality Ontario has picked up 4 of our indicators, has made them public on their website already. We have 1,200 nursing homes. They are voluntarily participating in our initiative. So far they were participating because they knew it was private.
Yeah.
When it becomes public, it will be interesting to see what happens.
Mhm.
I think that the public nursing homes will have to stay in. The private nursing homes may have a problem.
Yeah, either way, an improvement, it's good.
It will be very interesting to see what happens.
Yeah.
So anyway, so that's just our website. So just to give you a sense of what we are doing around performance reporting, because we are doing lots of things. The first thing we did is that we tried to clarify our conceptual framework. On our website, you have a health system performance framework. You also have a hospital framework, which is there for consultation. If you have any comment on that, we'll be very happy to receive more comments. We've received actually quite a bit already, but it was already a good starting point because there are so many frameworks out there. We were able to clarify what is our national framework around health system performance. Second thing, series of public websites. That's the one for the general public. We're working on the next round, which is one for hospitals, one for regional health authorities. We have already products around that, so that's really the next generation of products. More functionalities, more ways to look at the data in their entirety, and so there will be dashboards, there will be radius functions, so you can actually pull the data very easily in a table just by showing like a geographical area. So it's going to be really cool. Then the long-term care public website for November. Next thing we are working on is actually a private tool, which is a private analytical tool through which you can enter a private environment. So it's only for system managers, but the question will be, are we going to give access to researchers to this tool? You can actually drill down to the chart level. We're not there yet, but we'll be there in a year. You'll be able to look at things like readmissions, wait times for emergency rooms, and the third indicator, which is mortality from major surgery, I think. And so you'd be able to drill down straight to the chart level. Obviously, it's anonymized, but you'll be able to do actually lots of grades of the data. So it will be very powerful in terms of very granular analytical work you can do with that. What we want to do over time is to build the same type of tool in a standardized way across our data sets, so that at the end of this journey we can actually link across the data set and you can follow up patients across the healthcare system. So you can look at your long-term care resident who has been, hospitalized or went to an emergency room because they couldn't handle it, which happens all the time, because they don't want to take care of them themselves. So that's the next one. And the last thing we are doing around performance, our health system performance agenda, is capacity building. So we've been working, we developed a curriculum for system managers for a sort of 3 days workshop to help them first make a diagnosis about how their region is doing, and second, start thinking about an action plan on priority improvements that they think are required. We developed the first module, which we piloted in Atlantic Canada. We work with academics there, and now it's been actually very successful. So we had about 30 people who are VPs of decision support and performance measurement and accountability in their region. They came sometimes with their analysts working in their teams, and we got them to work as groups, brought in some experts and engaged them in a discussion about performance and performance improvement. And this model we're going to start implementing across the country starting next year. So we have one session in Ontario and another one in Western Canada. And that's okay.
Thank you. Okay. Thank you very much, first of all. And you're welcome to join us for lunch.